Welcome back to episode 10 of the MEE-FIT podcast. Today we switch up a little bit. I am the host and Dan is in the hot seat. He is going to be being interviewed today. Today's podcast is going to be all things joint health, kind of training related to all things, joint health is going to be our main topic for today. So start off with then, Dan, what is joint health and how can we relate it to kind of training? That's quite a
So I think what we mainly want to discuss is kind of the potential issues people might face with their joints and the impacts that might have on them when it comes to training. We work with a lot of clients here, predominantly 50s, 60s, even into 70s, and at that stage of your life, very often people will struggle with their joints, often knees, hips, spines as well, shoulders, ankles, you name it. We usually deal with it, don't we? So that's kind of what we're referring to. And in terms of when we say what is joint health, I suppose we're thinking about it from two angles. You've got what's actually going on structurally within the joint, and then also what the person experiences in terms of pain, discomfort, flexibility. And that's a big topic that I can discuss today. But those two things are not the same. Like there's a big difference between what someone might see on a scan or an x-ray, for example, or an MRI versus what that person will experience in terms of their pain level or any discomfort level. So that's really what we're referring to, injuries, chronic or acute injuries, but around the joint.
Yeah. I think the most common we see is kind of arthritis, isn't it? That's the main one.
Yeah.
Yeah, and there's loads of other different types, isn't there?
Yeah.
Loads of different types. But so how can exercise help conditions such as that, like arthritis and stuff?
So arthritis is a really interesting one. And the one thing I thought would be worth discussing really initially is kind of like what I just spoke about there in terms of the relationship between those two things, because I think people typically view it, the understanding is that your joint health in terms of your structure within your joint is representative of what your function is like and the actual what you can do with the joint. Okay, so for example with osteoarthritis, lots of people have osteoarthritis in terms of their joint. So there's lots of studies been done on this where they take people who are what we call asymptomatic, so people who don't experience any pain. So let's think about knees, for example. Osteoarthritis is probably the most popular one we deal with. The studies that have been done that have took asymptomatic people, so people with no pain, no injuries, no discomfort within their knees, and they x-ray them, they MRI them, and they look to see what's going on within a pain-free joint. And they very often find degenerative changes. Yeah. So things like osteoarthritis, degeneration of the joint in terms of the meniscus cartilage, which is within your knee, the actual joint surfaces, ligaments, ACL, ligament, all these changes, osteophytes, which is where your sort of joint has been damaged and starts to heal. Like there's all these things that they find, and these are in non-injured people. These are people with no pain, no injuries, and that. The prevalence of that gets higher as you get older. I don't know the actual stats off the top of my head, but I know I've seen social media posts and stuff that have been done where they've kind of showed like what's the average percentage of people in their bracket of ages 30 to 40, and then 40 to 50, 50 to 60, 60 to 70, etc. And it does increase as time goes on. But these are people who are completely pain-free. So what that tells us, and that's not just the knee, that's been studied all across the body. Spine has really been looked at. Things like, again, degenerative changes of the joint, so the facet joints, the discs, so prolapse discs, slip discs, for want of a better word, like that's what people typically call it, and all these other really scary sounding things, spondylolisthesis, all these like really like big scary words, but these are again people who are pain-free.
What causes the pain then?
Well, that's the big question. That's the big question. And that's what people maybe don't appreciate is pain is a really complicated experience. It's not as simple as you have got damage within your joint and therefore you have got pain. Because if it was, all them people who are asymptomatic and have got those degenerative changes, they would all be in pain, but they're not. And that's the really difficult part with it, because we can't know from what's seen on a scan or an x-ray or an MRI or whatever, we can't know for certain as to whether that actually relates to someone's pain level. Yeah. Because with an MRI scan, for example, you're getting a snapshot of what does that joint look like today, right? But it might have looked like that 2 years ago, yet the pain wasn't there.
Yeah.
And that's why I always kind of encourage people to question it a little bit when people are sent for x-rays and MRIs on injuries that are quite new. I mean, we've had it here before, like, you know, a client who's never really had any knee discomfort, maybe their knee starts hurting a little bit, or maybe they do something, whether that's in the gym or away from the gym, and they twinge their knee a little bit or something. They go and see their GP, and the GP says, I'm going to send you for an MRI or an x-ray. And I'm just like, no, don't do that, because you're probably going to find something.
Yeah.
And again, research has showed us that early scans for people, especially around the back, so back pain, early scans, x-rays, MRIs, generally worsens the outcomes.
Yeah.
And I think what happens, my understanding of it is that, you know, let's take an example of someone mid 50s or 60s, something like that, never had any back pain. They have an acute episode of back pain, so they hurt themselves gardening or picking something up, or it just starts to ache. It might just be more of a gradual thing, but they've never had any back issues before. You know, they might get maybe some neurological symptoms, so like pain down the leg and stuff. But it's the first episode, and you know, they're quite quickly often sent for a scan or an MRI, and like I said, the research typically shows they're probably going to fare worse, because what often happens is they go for that scan immediately. If the doctor says to you, I'm going to send you for a scan,
you think the
alarm
worst,
bells ringing straight away. Oh my God, what's wrong with me? I'm going to be crippled. I'm not going to be able to walk. All these like really, and they call it the nocebo effect. So most people have heard of the placebo effect, which is the, like, how do I describe it? The benefits that you might experience from something that aren't really there. They're not physiologically different. You're just psychologically you've experienced a benefit, and the placebo effect is really, really powerful. Really, really powerful.
Yeah, massively.
But then the opposite of that is what's called the nocebo effect. So it's basically nothing's changed structurally, biomechanically, physiologically, but suddenly someone's pain is heightened, and that really often happens. You know, the minute the GP says to you, I'm going to send you for an MRI, you're thinking, oh shit, like, what's wrong with me? Something bad's going on, like, oh, the doctor's really worried. You know, so that straight away they're going to be on edge, and they're going to be experiencing potentially heightened symptoms, or they're just even more mindful of their symptoms. Then they go for the MRI. That's quite a clinical experience, which again is probably not going to help someone's like mindset towards their injury. And then very often what happens is, you know, if they're in their 50s and 60s, they're more than likely going to find something that's wrong, and I'm putting wrong in quotation marks, because we don't know if it's wrong, because it might have been there for 5 years, if not longer. Like, we can't know. So, and that's what often happens to people, is that they're down this rabbit hole of, oh, I've got this tear in my meniscus if it's a knee, I've got this bulging disc, I've got this, and those things may be relevant, but they might not be relevant. Yeah. And that's the really difficult thing for people to understand. So you can probably tell I'm not a big fan of people going for MRIs and x-rays unless they're absolutely needed. And what that looks like is difficult to say. But if it's, you know, if it's a long-term injury, severe neurological symptoms, you know, crippling pain, like there's things that you would think, okay, maybe there is something going on that needs to be rectified. But a lot of the time, I think it's not a good idea, because you're exposing yourself to something that you don't really need to know. And I think they're banded out far too easily. I think far too many people are sent down that route when they probably shouldn't have been. No. And I think what we've got to start maybe promoting more as a fitness industry, a medical industry, whatever you want to call it, is helping people understand that the changes you see on an X-ray, on an MRI, are just normal. Yeah. They're normal aging. They're going to happen. Like, we all age, we all understand that externally, right? We get grey hair, we get wrinkles, we lose our sight, we lose our hearing, all these like degenerative changes of our structure on the outside, and we're all okay with that. Yes, okay, we all do things to try and help that anti-wrinkle cream and dye our hair and stuff, but we all accept that it's just a normal aging process. And what we've got to understand is that happens inside our body as well. I've
never thought of it like that, to be fair. Like, it's going to happen, isn't it? Your knees and stuff, they've been working 40, 50 years. They're going to get tired and start to...
Yeah, but what that people need to understand is that, it's normal, and it doesn't mean you're going to experience pain. No. Now, some people do, but some people don't. Yeah. And why that person doesn't or doesn't, that's the difficult part to answer. Because, you know, you could have... I've seen it before. When I was more of a sports therapist, when I did that for my degree. I was a sports therapist, and when I did kind of treat people with that, I remember I had someone who had very, very bad hip osteoarthritis, really, really stiff joint, very, very painful, could do very little with it. He came to me to try and help get better, which he did see big changes, but it was only so much. Eventually went down the route of, okay, I'm going to have a replacement hip. And as part of that process, he had an X-ray, an MRI scan on both hips.
Yeah.
But only one was symptomatic. The other hip was sort of completely fine. He had no issues with the function of it. But the X-rays and the MRI scans, there was barely any difference.
Wow.
Like the degenerative changes within both joints was basically the same.
Yeah.
And I remember reading the kind of report that this guy got sent from the consultant before they went down the surgery, and it highlighted that how the left and the right hip were basically very much the same joint, but the one was highly symptomatic and the other one wasn't. So what's caused that?
Yeah.
What's been the catalyst between the whichever one it was, the left or the right, I can't remember, being painful? I don't know.
Yeah.
But that's what I mean. It's a real minefield because you just can't know, and often you're seeing a snapshot of something that, like you said, could have been there for a long time. So it's a really, really difficult issue, but that's the big message from me, is like people need to start treating viewing their internal, when we say degenerative changes, as just a normal bodily process. You hear this term like wear and tear. I hate that term because it scares people. It makes people think that exercise and moving your body is not a good thing to do. We hear it all the time. People say, I played a lot of sport when I was younger, that's why I've got osteoarthritis. The data doesn't support that.
Might not have been that
at all. The data shows us that the more active you are, you're going to have better joint health rather than worse. Within reason, there's always extremes on either end of the spectrum. If you sit down all day, every day and never move your body, that's not good for your joints. If you run, 3, 4, 5 marathons a week for 20, 30 years, that's not good for your joints. But in the middle, there's a balance between that. And I think that's what most people should strive for, is maintaining a healthy, movement and exercise.
Definitely.
And whether that's work related or whether that's like more formal exercise. But I dislike the term wear and tear because I think it makes people think that what they're doing is damaging their body, but actually the data doesn't support that at all. So we want to encourage people to move their body. We want to encourage people to stay active, to even with things like osteoarthritis, exercise is a fundamental part of the management of that.
That's the next bit we're going to go on to. How does kind of exercise play a positive role in joint health? Like how does doing a regular gym session, how's that going to help arthritis, etc.?
So I think it might not help the joint itself in terms of structurally. If we take someone who's got, let's say, osteoarthritis, let's use that as the main area of conversation. Like if you take someone and you get them stronger and fitter and more flexible, the actual joint itself might not change. It sometimes does, and there is studies that have looked at that, where you get people with osteoarthritis, get them more active and see what happens within the joint in terms of the structure of it and the health of the joint. And you sometimes do see improvements, but you might not. But what you will find is that if you do get fitter, increased strength, increased flexibility around the joint, it's usually only going to be a positive thing because you're giving your joint, let's say it's a knee, you're giving that more strength, more flexibility to deal with the everyday activities that you're doing, that you're struggling with. So I'm a big believer, and all of the current guidelines in terms of managing osteoarthritis all have exercise as a core principle within the management of it. And again, leading back to what I just said about wear and tear, like that's why that term is not good, because it makes people think that if I exercise, I'm going to do myself more damage, which is a really, really sort of bad mindset to have. And it's something that we should really actively try and encourage people to realize that's not the case. You're only going to do your joint good with, again, doing things
in reason,
doing things properly, doing things with good control, and not just thinking, okay, I've got a bad knee, but now I'm going to start doing, run a marathon or whatever. Like it's got to be a progressive, structure behind the training. But providing you're doing that and you're doing it effectively, then it's only going to have a positive effect on whether that's the joint itself, but most certainly the symptoms. And we see that all the time. I can think of loads of clients just off the top of my head who have got a lot more flexible. They've increased their strength.
I was thinking of Claire, who obviously didn't have to have that.
We did a social post about that, didn't we? You know, someone who, was booked in for a knee replacement, ended up not having it. I think she's having a little bit more trouble with it now when I last spoke to her, but, you know, it's definitely delayed it at the very least, you know.
If anything,
And then again, like other people who've just, you know, they've come and they can barely squat because their knees are really stiff, and then like 6 months later, 6 months later, whatever, they're bending down, they're picking things up off the floor, they're flexing their knees a lot further than they ever did, a lot less pain. So, it's definitely a big component when it comes to managing it. Yeah.
Would you say strength training is the best way to benefit that?
Yeah, I mean, I'm always really mindful, probably a lot more than I used to be. I'm being too sort of, this is the best, you know, because like for anyone who's not exercising right now, going and doing anything is better than nothing. And I'm a big believer in that now. I definitely feel like I've softened as the years have gone on in terms of not being too regimented, like this is the best thing. But in saying that, yes, like the evidence and the research sort of shows us that a weight-bearing, resistance-based exercise regime is always going to be the most beneficial, because what we're looking at really when we think of, if we think a bit more about, going a little bit off topic, but more about like general aging, if we think about that, we think, you know, we spoke about the degenerative changes that happen within the joint. We've also got things like sarcopenia, which is the age-related loss of muscle. So as we get older, we lose muscle tissue, and we lose it at a pretty fast rate, really, over the age of sort of 40 and 50. We've also then got what we call osteopenia, which is the age-related loss of bone mineral density. And again, that's something that accelerates as time goes on. So every year that we don't do anything about it, our body is getting worse. You know, the structure of our body, in our muscle, in our bones, in our joints, is getting worse. So the sooner we counteract that, the better. But the main benefit around strength and resistance-based training is you're dealing with the muscle mass, because you're giving it a stimulus. You know, every time you lift something, whether that's in the gym or outside of the gym, you're giving your body a reason to maintain the muscle because you're using it. You know, you hear that phrase, use it or lose it. It's really true when it comes to muscle. Like if you don't train your muscles, you will lose them. And you see a big difference between people, you know, as they age, in people in their 40s, 50s, 60s, compare someone who, you know, before I say that, I will always say there's always a genetic component with this. Like some people just genetically are predisposed to muscle loss. Some are predisposed to muscle maintenance. So there's always that variation. But like typically someone who's worked in, let's say, an office for all their life is going to, generally speaking, have less muscle by the age of sort of 40, 50, 60 and, you know, beyond than someone who works in a more manual setting. Let's say you know, we get people here work on a farm, or they, you know, they work with horses or something. I don't know, something outdoorsy where they're lifting things, they're carrying things. Quite strong,
don't they?
Yeah, because they're using the muscle that they've had, you know. So got off topic a little bit there. But yeah, so we're thinking about maintaining muscle mass. We're thinking about maintaining bone mineral density. We're thinking about, you know, improving or helping the joint. So what we don't get with some more cardiovascular exercises, and again, this links back again to that, like my dislike of the word wear and tear, right? Because I think that's what leads a lot of people who are in their sort of 50s, 60s, 70s, etc., to go swimming. You know, they view swimming as it's a safe, you know, it's safe for our joints, it's good for our joints. But actually, it's not a bad form of exercise, but you're not getting the weight-bearing load which you need. So, you know, yes, I do believe a properly structured strength training protocol is going to be the most effective. Now, if you add in walking, swimming, cycling alongside that, brilliant. Looking after your cardiovascular health is also really important. But I think from a perspective of joint health and also muscle and bone loss, the strength and resistance-based training is definitely the most effective. And also, it probably passes across to everyday life, you know, more effectively. Like if you get better at swimming, you get better at swimming. Whereas if you get stronger within a gym setting, that's more likely to pass across to the gardening, the playing everyday with the grandkids, the getting up and off the floor, like all the everyday stuff that, again, gets harder as you get older. So, yes, I'm a big believer in strength training, hence why we prioritise that here. But there's also big benefits around improving your cardiovascular health. And if people enjoy swimming, cycling, walking, running, potentially, like, great, do those things. But ensure you're doing the strength training as well, because it is really, really important. It's
got to be structured and obviously right technique and everything like that. It's got to be,
and I think progressive. And I think that's what worries people, is they think, you know, we hear it all the time, people who are worried about getting started here, I won't be able to do it, I won't be able to keep up, I won't be able to, you know, and I think that's where a service like ours is different than a more conventional gym, let's say, in terms of the fact that, here we work closely with the clients. We make sure that they're doing everything correctly. They're working at the right level. They're progressing themselves over time, and they're not just kind of left to their own devices. And I think that's a big barrier for people, especially if we're thinking about people in their sort of 40s, 50s, 60s and beyond. One of the big barriers is like, I don't know what to do in that environment. And that's why I think people, who find our service are so appreciative of that, because they're getting that support and that guidance that they need to do the things that they need to do.
I think people get scared they're going to make it worse as well. I think that's probably something that you hear quite a lot. And I know people kind of, do mention it as well. They don't want to do any more damage as such. But
which they're not at any, really, the only real risk of that is doing too much too soon or doing something that your body is not capable of doing. We talk about form and technique, but your body will adapt to the stimulus that you give it. We have a bit of debate about this, but like form and exercise technique is individual in the fact that some people have got different flexibility, their joints move differently and stuff, and we've got to be able to kind of deal with. But I think just making sure that you don't go and push yourself too hard, work at too high intensities or do things that your body isn't capable of doing. That's when you're at risk of potentially injuring yourself. But as long as you're doing it in a structured manner and over time progressively getting stronger and using your joint through a greater range of movement, then that's only going to be a big benefit to the overall joint health and the symptoms that person experiences, the strength and their flexibility levels.
That's why obviously gyms like us are great for people, because they don't have to worry about any of that. So we do it all for them. We do obviously all the programming and stuff like that and kind of take them through. But it kind of leads on to our next topic, like how do we look after people with joint problems and how do we kind of adapt sessions and stuff like that.
Okay.
Bit about us.
Yeah, so I think, anyone who's a member hopefully will know what we do here, but anyone who's sort of listening who isn't, like, our big focus here is, we provide personal training. We do it in a small group environment. And what that means is that we can work closely with each client. And a lot of the times with us, that is, working around injuries. We've got a lot of clients, like we mentioned earlier, with knees are probably the most common thing, I would say. If we had to tally it up, I would say knees are probably the highest. But do you
think there's any reason for that? Has there been something to show that they kind of?
I think the knees are probably one of the most load bearing joints in the body. So that's probably, I've never really looked into it as to maybe why it is the most prevalent. So no, I don't know the answer to that question. But yeah, I'd say it's probably a lot to do with how much flexibility you have at the knees. They do a lot of the movement when you think about what you're doing on a day-to-day basis with your legs.
You do a lot.
You do a lot with the knees. Like the ankle doesn't move that much. The hips are very, very strong and congruent joints. So, but we do have a lot of hip, clients with hip issues, don't we?
Knees just seem to be.
I don't really know, but knees are probably the most common joint where you're going to get osteoarthritis, or you're going to have symptoms of osteoarthritis. So we'll always have a conversation with a client whenever we get in someone new started. Obviously, they'll usually fill us in on what's going on, and then the initial kind of consultation for us. One of the big parts about it is the movement screening. So a new client will come in, and a big part of that initial session is, establishing where they're at with their joints and with their, if they have got any previous injuries, we'll have a little bit of a chat with them about that and sort of see what we can and can't do. Is there anything that's particularly off limits, which sometimes there is for some clients, but and then it'll just be a case of us adapting it, the first few sessions, just trying to really understand, like, within the sort of spectrum of things that we will do with a client, like, where do they need to start, and if we think about, like, knees, for example, we think of a squat exercise. We've got loads of different variations of that we will use. Some clients will come in and do squats to a high box where where we're limiting their range of movement. We're putting something behind them for them to take their bum to, so that we're limiting how much range they can go through. Other times they might do it holding on to something to give them that support and allow them to get that a little bit lower. Other times it might be that they do them straight away, just body. We've got probably 10 plus different types of squat that we will take a client through, depending on where they're at. So everything's just really well looked after each time. a client comes in who's new, who has got injuries, I'd like to think that the team are all fully aware of what's going on and how to best accommodate that. So yeah, they're just going to be very well looked after within that. And we always just ask clients to just communicate with us. If we ask them to do something that isn't feeling good, or they're a bit unsure about it, just speak to us, and we'll obviously try and help them with that, whether it's changing the exercise or whether it's just reassuring them that actually this will be a good thing for you to do if you can.
Yeah, definitely. Perfect. Is there anything kind of that people can do to prevent kind of joint health getting worse and stuff? So I know you said that it is kind of there from as you do start to get older, but is there anything people could do to help themselves?
Well, exercise being fundamental. Risk factors associated with osteoarthritis. I was looking at an interesting study about that recently that someone shared on Facebook. So higher BMI is definitely linked with osteoarthritis. So and that kind of makes sense. Like the heavier you are, the more your joints have, the more load is going through the joints. If you think about all your daily tasks, all the walking that you do, bending down, reaching up, all the functional tasks that you do every day, the heavier you are, the harder that's going to be for your body to do, and the more pressure that is going through the joints. So osteoarthritis is definitely, linked with higher BMI. So maintaining a healthy weight or trying to reduce weight if you are in the kind of overweight, obese categories, the research would indicate is going to be beneficial to you long term in terms of looking after your joints. Sleep disturbance seems to be another link. So, high quality sleep, sleep is where we regenerate our bodies predominantly, and if someone's having poor sleep quality or very little sleep, that's going to mean that the body's having less time to regenerate, and also is probably going to be more active as well. Like if they're only sleeping for 3, 4, 5 hours, that's 3, 4, potentially 5 hours more that they're not asleep, that they're doing other things, so you're going to be putting more stress on your body that way. Caffeine intake was also mentioned on this study that I saw, which is interesting. I don't know what the link is there. I've never looked into that, but that was just something that I saw. But I think fundamentally the big thing is just, exercising, keeping active, keeping fit and healthy. But there's so many factors that can influence pain, and that's why this is a really difficult conversation, because pain is really multifaceted. Like it's not, like we've already mentioned, it's not as simple as what's going on within your joint is going to impact your pain. There's so many other things that can contribute to that.
And everyone's got different levels of pain tolerance, haven't they? I think that probably makes a big difference.
And even things like almost like the environment you've been used to. Like we've seen this a lot. Like if we see it a lot in weight, like if someone is overweight, two parents who are overweight, often the child is going to be overweight because they're used to that environment, and I've heard people say about, I've got the surname, like the Joneses knee or something, where like everyone in their family has got a bad knee, like it's just like a generational thing. Now, is that genetics, or is that just that
you've been told
you've been used to having knee issues around you, so you're more prone to them from that perspective? I don't know. I've never looked into that. I don't know if there's any data or research on that at all, but that's just something anecdotally that I've noticed where, or the hip issue that the whole family seems to have, that is it any different than anyone else, or is it just that actually I feel like I'm going to have a hip issue because my mum had a hip issue, so did my nan, so did my grandmother, and it's just almost like the expectation that you're going to have a bad hip. So and pain's also, this again could lead us in loads of different ways, but like pain is so complex. Like back pain especially is an absolute just minefield of things that can contribute towards someone feeling back pain, and you have some people who go through their life all the time, like never have a back issue, move really awkwardly all the time in their work, like you look at them and you think, how is your back not hurting? And they're absolutely fine. And then other people, like they do everything perfectly, and then the one time they don't, you know what I mean? And so there's other factors that can contribute towards pain. Like this is something that I didn't learn about that much in my degree, because my degree was very sports injury related. So it was very much athletic injuries. I know I've twisted my ankle running, or I've pulled my hamstring playing football or whatever. But opening my own kind of mind to other things, I started looking more into pain as a kind of in and of itself, and I come across something that they call the biopsychosocial model of pain. So you've got three components. You've got the biological component, the physiological, and the social, and how those three things can influence someone's pain experience.
Wow.
And yeah, my degree didn't cover it, which I'm really annoyed about because it's really important, even in athletes.
Well, yeah, especially.
But even more so in non-athletes, in day-to-day people, like, things like, there's research out there that shows, if people are stressed, they're more likely to experience, back pain, money problems.
Yeah.
Again, more likely to, so back pains are really where it's not going to be caused by that, but it's going to influence it. It's going to influence how bad it is on a day-to-day basis. If you wake up one day, your life's great, you've got a great job, you've got a lovely family, you got enough money to do everything you want to do, and your back's a bit sore.
Yeah.
Oh, my back's sore. Whereas if you wake up, you're about to lose your job, you're about to lose your house, all these negative things,
and
your back's hurting, you're like, God, I can't catch a break.
Yeah.
It's way worse. You know what I mean? I know that's like a silly example, but like it is influenced by things. Yeah. So yeah, the pain someone is going to experience is difficult to predict, and it's really difficult to know what's the root cause. But the problem is, like we've discussed earlier, the minute it's a joint issue, we're often sent down that path of scans, X-rays, MRIs, which can open people's eyes to something that they probably didn't need to know. They probably just needed to manage. And a classic phrase that people use with that is, you need to treat the man, not the scan.
Yeah.
And that, I don't think, happens enough. Like, you start treating the scan. What does the scan say? Oh, the scan says we need to do X, Y, Z. But actually, the person doesn't need that.
No.
Does that make sense?
Yeah,
the person,
definitely.
The symptoms just need managing. They need to rest from anything that's particularly aggravating.
Yeah.
They need to have a phased, gradual, progressive return to those activities, rehabilitation, strengthen the joint, all those things. But they end up going down the route of surgery or something that might not be needed, or could be something that doesn't need to be done for another 5, 10, 15, 20 years potentially.
Yeah, definitely.
So yeah, that was a bit of a long-winded answer to that question, but as a general rule of thumb, to improve your joint health or maintain joint health, stay active.
Yeah.
Ideally, involve yourself in some form of structured resistance-based training. Definitely first on the list. Get good sleep.
Yeah.
Manage your body weight. Yeah, they're probably the main things that you can do, and then just hope for the best. In every other way, I suppose. But they're the main things you can do, I suppose, as a general rule of thumb.
Definitely. So, what would your advice be to someone who is suffering with some sort of joint issue? What would you kind of say to them?
So the first thing would be, don't go and get an X-ray on MRI.
Don't do that.
Don't do that. Firstly, it would be realise that it's normal.
Yeah.
Like you're definitely not the only person who's got that. And I think that's important because we all sort of sometimes feel like we're all this like special snowflake, but really like we're all very much the same. Like most people are going to experience back pain, for example, or joint issues over their years. Try and establish what potentially caused it. But at the same time, if you can't think what that is, don't overthink it. Like, and I see that a lot. Like, this is, again, slightly more prevalent with back pain, but people thinking, oh, it must be my mattress. I was on holiday and I had a different mattress, or I don't know, maybe I injured it gardening and it was when but if you don't know that you've injured yourself there and then, it's very unlikely you're going to have, it's probably not that. It's probably, again, it can be a load of different factors that can go into someone feeling, it's different. If you've bent over, you've picked something up and you stand up and your back suddenly hurts really badly, then you know that something that happened there was, but again, it doesn't mean that you've damaged anything. And I think that's the big message I want to try and give people with this is like, pain doesn't equal damage. So if you've got pain in your body, it doesn't mean that something is damaged or torn or stretched or anything. Like, it just doesn't. Like, the research doesn't support that at all. Like, pain is an experience that you will feel for lots of different reasons. So yeah, don't overthink it. If you've just got a progressively worsening symptoms, then you need to try and figure out, is there anything that's aggravating it particularly? Is there anything that you're doing on a day-to-day basis that's aggravating the symptoms? And stop doing that, immediately, just for now. Because, if you're doing, and again, if we relate it to the gym, if there's a particular exercise that you're doing or a particular movement that you're doing that really aggravates your symptoms, stop doing that for now while your pain is high. I'm not saying don't ever do it again. And that's, again, an important thing, because people, if someone hurts their knee doing a squat, I wouldn't want them to think I can never do squats again.
Yeah, no, definitely not.
Because I've hurt my knee doing squats before. It happens. Like, you we injure ourselves. Or even, the elitist athletes in the world injure themselves doing the things that they enjoy, 100-meter sprinting, football, rugby, whatever. So injuries are just a normal part of life. And so understand what's particularly aggravating it and find ways to adapt that or stop that for the time being while the pain is at its higher point. Allow that pain level to settle down, and then generally speaking it would then be a graded exposure back into doing the things that you were doing. And that's a big part. Again, I always linking it back to back pain because I think there's more research done on back pain. But one of the big issues people have post back issue, like post acute back pain, is they call it fear avoidance.
Right.
So it's avoiding things out of fear. And it's generally something that we want to try and avoid or move away from. And you can see it, you can see when people have injured themselves, if they've had a back issue, they drop a pen on the floor, they won't bend their spine to pick it up. They'll really stay straight and bend their knees, and they call that fear avoidance. So you're avoiding doing a movement out of fear that you're going to hurt yourself. And it's difficult, but it's something that you want to try and work on over time, because our bodies are made to move. We're made to flex our spines, we're made to flex our knees. If our joint shouldn't move in that way, it can't. So like my elbow, I can't take my elbow any further than that. It's not supposed to do that. But if it goes this way, it's supposed to go that way. And same with your spine. And that's, again, thinking about the back, like that's one of my pet peeves, is when you hear these, whether it's personal trainers or even physios, sometimes chiropractors, whoever, never do this exercise or never move your body in this way. You're like, just stop. You're frightening people. You're making people worried about moving their body. Your bodies are made to move. So, but immediately avoid the things that are particularly aggravating you. Manage the symptoms that you're experiencing. And then as your pain level allows, start exposing yourself more to that thing again until you're at a point where you can do it more freely. And that's generally the approach we take here. If someone's got a bad knee, we're not going to not do squats with them. We're going to find a way to enable them to do a squat so that they can strengthen their thighs, they can increase the flexibility of their knees, strengthen their knee joint, but in a way that is suitable for them and their symptoms. And that would always be my approach. You can't be too specific with things because everyone's a little bit different, but there's always a way that you can adapt something that you're doing to have the same effect, which is increasing the strength, increasing the flexibility, but around an injury. So my approach with injuries, I don't treat people with injuries anymore. Like I don't do it on a day-to-day basis anymore. But if we ever have clients here or if I'm ever having conversations with people, my advice is always the same: like focus on what you can do rather than what you can't do. And I think that's something that we have it all the time here, where people, they inquire, but I can't do it yet because I've got a bad shoulder, or I've hurt my knee, so I need to wait, or like maybe even a client here might come to us and say, I've hurt my shoulder, so I'm not going to come to the gym. No, still come.
Other body parts to work, isn't there?
Let's work your legs, let's work your core, let's work your cardiovascular system. What can we do? But it's a mindset thing. People are like, I don't want to hurt myself anymore. But you're very unlikely to. Your body will very quickly tell you if you're doing the right or the wrong things. Like if you're doing something and it really hurts, you're probably better off not doing that right now. But if something feels okay, it's probably okay, and then you can see how you feel afterwards and stuff. Of course, you've got to bear that in mind. But I'm always very proactive. You hear it all the time, like these more sort of, I would call them old school therapists who are like, someone goes to see them and they come out of a list of don't do this, don't do this, don't do this. And I'm thinking, well, what can you do? Did you talk about that? No. Right, okay. So you're just going to do nothing until the pain gets better. Like that's not a good way to approach injuries. The best way for me is like avoid the things that are particularly aggravating, like I said, but find the things that you can do, and you'll be surprised at how much that is. We've got, I won't name names, but we've had someone who's just returned from a knee replacement, who's back in the gym. Certain things she can't do, but loads that she can do. We've got like loads of examples like that of people who've got a particular issue. Let's work around it. Let's find a way to adapt it. Let's keep you getting stronger, fitter, healthier, improving your cardiovascular system whilst you're managing an injury or an issue.
I think people have a bit of a different mindset when it comes to the gym. Like outside the gym, if you rolled your ankle walking, you're not going to not walk again, are you? But I think when it comes to the gym, everyone's kind of scared of is possible and stuff. But as soon as they get in, they're fine, aren't they? But
and the gym's actually got a really low incident rate of injuries.
Yeah.
Like if you look at the studies that have been done looking at like different types of physical activity, like the gym is actually pretty low in terms of your injury incidence rate per. They usually do it per like 1,000 hours.
Yeah.
So for every 1,000 hours that you play of a particular sport, or how many injuries do you get? And like contact sports, like rugby, American football, like stuff where you're really smashing into each other, they're obviously absolutely at the top.
Yeah.
You know, but even there's a lot of talk around like CrossFit, like, you know, oh, everyone gets injured. Like, no, they don't. No. They don't actually. Like, if you look at the incident rates, it's still pretty low in comparison to loads of other things that people would probably deem safer than the gym. Yeah. But actually, the data doesn't support that. Like, the gym is probably one of the safest things. I think even swimming has a higher incident rate of injuries. Yeah. I don't know for certain on that. Don't quote me on that, anybody. But if I remember rightly, I'm sure swimming was higher. Like overuse injuries of the neck, of the shoulders, you know, things like that. So the gym's a very safe place. Yeah. Providing, you know, you either know what you're doing or you're looked after by people who know what they're doing and can guide you. It's actually a really, really safe environment. So, join the gym, get fitter, get stronger,
basically the message for today, isn't it?
Yeah. No, I mean, we have a bias towards this. And like I said before, you know, I'm a big believer in exercise fundamentally. Just from a health perspective, people should exercise and find the thing that they can do that can keep them consistent, whether that's spin classes, whether it's boot camps, whether it's swimming, whatever it is. But the research indicates to us strength training is, you know, arguably the best thing you can do. And especially, again, we're going off topic a little bit, but if we still talk specifically around aging, strength training is without doubt the best thing you can do for your health. Without doubt. It plays across into maintenance of muscle mass. You know, we've got a post coming up about Alzheimer's week. You know, brain function even has been linked with muscle mass retention. You know, if you can retain your muscle mass, you are going to be in a far better place for it as time goes on. And it's never too late to start. We did the summit that we did when we spoke about aging. You know, we looked at that, and there was there's loads of research been done that no matter what age you start, it's like saving money. Yeah. It's, you know, the sooner you start, the better. Yeah. But if you've not done it by the time you're 50, don't think, oh, well, I can't do it now. Because think where you'd be in 10 years' time if you started saving now. You'd be further along. So, you know, it's never too late to start strength training. It's never too late to start exercising in any capacity. No. But I think often people have this mindset that the gym is for young people. You know, and thankfully, I think as time is going on, gyms like ours and others that are actually working with clients who are in their 50s, 60s, 70s, who wouldn't typically usually find themselves in a gym, are showing people that actually the gym can be and should be for everybody. Yeah. You know, and especially as you get older, even more reason, in my opinion, to be in the gym, because that you're at a point there where your muscle mass, your bone mineral density is all just getting worse and worse and worse.
It's a great time to start, really, isn't it?
Definitely. Yeah.
As it starts to.
Yeah, absolutely.
Definitely. Any final thoughts? Anything you want to kind of finish on?
No, I feel like we've covered a lot of different things there. We could have had another podcast specifically on aging. Maybe we'll add that one to the list.
Tom to do that one.
But no, general thoughts. Don't go and get an MRI and X-ray unless it's absolutely necessary.
That's the main point for
That's
today.
The main point for today. No, they've got their place, just to be clear. They have got their place, but don't rush into it. Deal with your injuries like conservatively first. Yeah. Like surgery for me, because that's often where those things lead. Yeah. Like they're leading to surgery. For me, in my opinion, that should be like the last resort. Yeah, last rather than the first point of call. And that sometimes isn't the case. You know, knee replacements, like how many people have I seen with knee replacements who, you know, they're considerably overweight, they don't exercise, they live a really unhealthy lifestyle. Like, could we have like maybe dealt with those things first? Maybe you didn't need the new knee. No. Maybe you just needed to like try and lose some weight, get fitter, get healthier, get stronger, do all those things. You know, so yeah, they're my thoughts. Join a gym, find an environment where you can be effective in that environment, exercise, and
great. So if you're happy then, thank you for watching, everyone. If you do need any more advice on anything that we've spoken about today, don't be scared, drop us a message and we will be in touch. Thank you again.